Mike. Well, thanks very much. Dr. Merson probably doesn't remember, but in 1989, he sent me to Pakistan to track down drug-resistant bacteria causing pneumonia in kids. That mission actually took me to Abbottabad, Pakistan, and we didn't know that there'd be greater fame for Abbottabad ahead of its time. But anyway, this is really the most fun part of my job. Like I said, I've had a 30-year career in global health. And so I've been doing this, sort of interacting with students like yourself and people early in their careers. It's really one of the most fun things that I want to do, that I like to do. So I'm going to give you a quick overview of the sort of what we are, who we are, what we do. And it was a real challenge to trim this down. So I only have 200 slides, so I'm going to talk very fast. But I hope to leave time. I plan to talk for 30 or 40 minutes and leave time for questions at the end. But let me launch into this. So our mission is to improve the lives in lasting ways by advancing integrated, locally driven solutions for human development. FHI has expanded its scope over the last few years. As Mike implied, we've become a 360 organization. But let me tell you, this is a one slide on our history. We started in 1971, spun off from the Carolina Population Center as the International Fertility Research Program. In 1982, became known as Family Health International. Then a major event occurred 3 years ago when FHI acquired another NGO called AED, which did a broader scope of work beyond what our roots had been. We started off doing contraceptive technology in the 70s. In 1986, with the expansion of the AIDS response, got very involved in HIV prevention programs. Started doing work in HIV and other infectious disease research in the 90s, working with NIH-funded research networks. We were innovators in HIV treatment programs starting in the early days of treatment globally in 2001. Got interested in broader development. And then when we acquired AED, that took us from a group that exclusively worked on health to a group that does broader things that I'll talk about in a little bit. So the 360 invokes a full circle of development activities. But I oversee our health portfolio, and that's what we'll talk about today. So today, FHI360, with our headquarters, according to my MapQuest, 2.8 miles from here, in the Diamond View 3 building on Blackwell Street on the American Tobacco campus. We look right down into the Durham Bulls baseball stadium, so we can't wait for spring training to get started. But we now, as we have our headquarters there, we have a large office in Washington, D.C. in DuPont Circle, and we have more than 4,000 staff globally, working in 60 countries around the world. We have a large Asia-Pacific regional office in Bangkok. We have an office in Pretoria, South Africa, that works as a regional office. But we have our staff in 60 countries around the world with 30 large country offices. We're one of the larger NGOs. Our revenue last year was about $660 million, funding research and programmatic activities. About 2/3 of that from the U.S. government, the rest from a smattering of foundations and other governments around the world. So we're a very matrixed organization, and I'll get through the organizational stuff quickly, but we have 3 technical sectors, and I'm the head of our largest sector, which is global health, population, and nutrition. We also have a group that does social and economic development, work related to livelihoods, peace and democracy, environment, gender, and youth activities, and we have a global learning group that does educational programs around the world. And then we have 4 geographic areas, and they're matrixed in that people work across these. So our people from our health group interdigitate with our 4 regions: Asia, the Pacific, East and Southern Africa with an office in Pretoria, West Central Africa, and MENA, which is the Middle East and North Africa. And we do have a robust U.S. programs working in education and social marketing and communication. The tagline for FHI360 is the science of improving lives. So we put a great value on generating evidence, publishing that, and make sure it's presented in international meetings and published. So we're just still counting up 2013, but in 2012, FHI360 authors published 193 peer-reviewed publications, with more than half of those having impact factors above 2. So we do value this very highly in the organization. This is the group that I oversee, and you probably won't be able to read too much of this, but this is our Global Health, Pop, and Nutrition group. We're organized in these various compartments. Some of you may know Carol Hamilton, who's a long-term Duke infectious disease doctor who joined us 5 years ago. We have departments that oversee contraceptive technology development, integrated health sciences with clinical and epidemiologic science, HIV, tuberculosis, malaria, neglected tropical diseases, diarrhea, and pneumonia. Our Program Sciences Department is the group that works mostly with our country programs around the world, with family planning, research utilization, which is taking evidence and turning it into programs, technical assistance. We have a passion for implementation science and health services research, monitoring evaluation, and lab sciences. Health system strengthening is sort of an underpinning of many of our country programs around the world. Our global health communication work does a lot of social behavior change communication. Within this, we have a team that does water, sanitation, and hygiene, and much of that work is based on behavior change for healthier behaviors. And we have a program I'll talk about later about emerging pandemic threats. Our science facilitation department, about 60 people, that sits on our Durham campus, that runs research networks for the Division of AIDS at the National Institute of Allergy and Infectious Diseases. We're the core operations center for the HIV Prevention Trials Network, the Microbicide Network, and the Mother and Child Transmission Network. We have a very robust group of social and behavioral scientists, all here in Durham. A nutrition team is very robust, mostly based in Washington. I'll talk a bit about those activities. And here in Durham, we've got a strong team of biostatistician and data management folks that work across these. So this is the team. About half of these people are in Durham. About half are in Washington. There's 350 people in this group, including about 80 doctoral level scientists, and I'm sure more than 100 master's level scientists of all stripes working on these domains. So it was a challenge to figure out what to talk about when I came to see you today. So I'm going to give you a potpourri of things. But this is really what our work is about. We believe in generating evidence and then making sure that that evidence gets translated into programs. So whether you call that research to practice, evidence to action, or research utilization, that's kind of our sweet spot, working in that space between both generating evidence, make sure it's translated into programs, and making sure those programs have public health impact around the world. And that's sort of a unique role in the NGO world. There aren't too many groups that are both doing the research side and also doing the program side. When we think about what impact we have, we reflect upon, I'm sure you're all familiar with the Millennium Development Goals, and the target for these is 2015. We work in health, of course, on child health, maternal health, combating HIV and other infectious diseases, but other parts of our organization certainly impact all of these. And our roots in family planning convince us that really family planning helps all of these Millennium Development Goals. And several of our sectors are engaged in the discussion beyond 2015, beyond the Millennium Development Goals, what are now called Sustainable Development Goals. And there's quite a wrangle going on globally to figure out what the priorities are going to be for the world in development going forward. So we like to be part of that conversation as well. The way we sort of engage, we very much have our programs aligned with the priorities of countries. So we have a country-centered delivery model, and increasingly with our variety of work, both within health, but also social, economic, and development education, having those things be aligned in a common platform. So I'm going to walk through some of the things we do in a couple countries. Nigeria is our largest country presence. These are 5 large projects we've got there. We have more than 600 staff in Nigeria doing this large portfolio of largely U.S. government-funded projects, but also some things from the Gates Foundation. CIDAS, I'll talk a bit about. This is a $220 million USAID program working on comprehensive HIV and AIDS. A TB care program also with USAID with a focus on multi-resistant tuberculosis. C-Change does a health communication, but geared towards HIV prevention. Another HIV prevention program here. And this is our largest malaria project. It's an $80 million USAID-funded malaria project doing prevention, control, and treatment of malaria. So just a bit about Nigeria. It's the largest population in Africa, 160 million people with a tremendous burden of health diseases. Showed in the color here are the states where this one project is going, CIDAS, which is strengthening integrated delivery of HIV/AIDS services. It's USAID's largest single project in the world, and it's having tremendous impact with focusing on health, but also leveraging activities in health communication, education, and gender work. We're currently working in 22 states, and over the last 10 years have worked in a broader range of states. We currently are involved in a very accelerated ramp of prevention of mother-to-child transmission targets. The U.S. government, you're probably familiar with the President's Emergency Plan for AIDS Relief. All of these HIV programs are done under PEPFAR. They're PEPFAR programs. And it's a very target-oriented initiative. And Nigeria is one of the countries that's behind on its targets. And it's viewed, there's a lot more resources going into Nigeria to try and hit targets of how many women get on antiretrovirals and how many HIV-infected people get treated. So this just shows the kind of impact. If you remember, 10 years ago, very few people in Africa were getting HIV services and certainly getting treated. So this is the ramp up of pregnant women that know their status based on our programs in Nigeria. So now more than 2 million people, 2 million pregnant women have had their HIV status tested over the last several years. This is the number. More than 60,000 HIV-infected pregnant women have received antiretrovirals around the time of their pregnancy. So this has likely averted 15,000 mother-to-child transmission events. So there are 15,000 children in Nigeria that are not HIV-infected that would have been if they hadn't been able to have these programs. And again, this is PEPFAR, the USAID, and some support from the Global Fund as well. These are our numbers in Nigeria on antiretroviral treatment. Nearly 250,000 HIV-positive patients have been started on antiretroviral treatment over the last, this is about 6, 7, or 8 years, and the majority of them are still on treatment. And this is contributing to the global total of about 10 million people now on antiretroviral therapy in developing countries globally. And 10 years ago, that number was in the tens of thousands, going from tens of thousands to 10 million. And it's programs like this that have allowed the world to have that tremendous ramp up. Tuberculosis is a big problem in Nigeria, and because of challenges in programs beforehand, multi-drug resistant TB is a substantial problem. So with support of USAID, we were able to develop the first laboratory that was able to diagnose multi-drug resistant tuberculosis in the proper biological safety, to culture the bacteria, determine its biological susceptibilities, and then managing it appropriately. And this is a special multi-drug resistant TB ward that was developed in the Calabar state of Nigeria. So again, this is all part of the President's Emergency Plan for AIDS Relief, dealing with the comorbidity of tuberculosis, very closely linked to HIV infection. Well, I should say, I'm happy to entertain questions during this, so if something doesn't make sense, if I get it wrong, or you simply have a question, just raise your hand and we can ask questions. Then we'll also leave time at the end for questions. Also in Nigeria, we have our largest malaria project. In some regions of Nigeria, malaria is a substantial problem. Shown here in color are the states that have the highest malaria burden because of the local ecology there. So LGA is a local government area, sort of the subdivisions of states. So there's a population of nearly 30 million people that are being reached in these states with a comprehensive malaria program. Do any of you folks do malaria work? We've got a couple malaria experts in the room. So this is the elements of this program. It's to increase access to malaria prevention interventions. A main one is a long-lasting insecticidal net. So you sleep under a net at night that has insecticides, and if the mosquito lands in the net, the mosquito will die, and it won't bite you. Intermittent preventive therapy for malaria for pregnant women. Improved malaria diagnostics. There's some exciting new rapid diagnostic tests for malaria, and appropriate treatment using artemisinin and containing combination therapies. Increased awareness and knowledge of malaria prevention and treatment services. Improving capacity of the program. A lot of our work is based on capacity building for local organizations and ministries to do this work, and to strengthen the management information service systems for the local states and local government areas. So these are just a couple. Again, the capacity building is a big part of what we do. So these are actually training on using new rapid diagnostic tests. The key element of malaria control is making sure you're just using their drugs for people that really have malaria. So if you can sort out who has fever due to other things versus this, you can have a more focused use of appropriate malaria treatment. The logistics in Nigeria are challenging, particularly in the north, which has been a war-ravaged part of the world. I think this is our only FHI360 camel. But this is what we use for distributing bed nets in some parts of the country, and this is a market where the bed nets are distributed and sometimes socially marketed. And this is sort of in a village level giving a demonstration on the proper use of a bed net. And these really are one of the major modes of avoiding malaria transmission in a place like Nigeria. Zambia is one of the other African countries where we have a very large footprint. This is sort of a map of where the programs are. Just quick, they're all U.S. government supported. Most of them USAID, but one of these is from the U.S. Department of Defense. So the Corridors of Hope is a program that works at cross-border movement of people at high risk for HIV infection, which includes female sex workers, truck drivers, and other people that move around and by virtue of their movements are at high risk for HIV infection. FANTA is a food and nutrition technical assistance program. SPLASH is a water sanitation program for schools in particular, encouraging hand washing in schools and appropriate use of water. TB Care treats TB. Thrive is another feeding program for families affected by HIV. This is the Zambia Defense Force Prevention, Care, and Treatment Program, dealing with HIV prevention for military populations in Nigeria. Again, the U.S. Department of Defense is part of PEPFAR, and they have a partnership program with other militaries. ZPCT2 is a Zambia Prevention, Care, and Treatment Program, and this is Zambia Prevention Initiative, which does this comprehensive programs on prevention, care, and treatment around the country. And this shows you the map of where these programs are located. And again, this is another example of the scale up. So shown in blue, in one northern state of Zambia, the number of people who've been identified as HIV positive, nearly 600,000. And of those, nearly 200,000 now have been started on antiretroviral therapy. So again, another example of these large programs going to scale, reaching large populations, and providing the life-saving antiretroviral treatment. In Vietnam has a very different kind of HIV epidemic. In Nigeria and Zambia, it's a fairly generalized heterosexual epidemic where virtually everyone in the population is at risk. Vietnam has a much more concentrated epidemic. And there's a lot of emphasis on the cascade of care and treatment. Are you guys familiar with this concept in your public health training? It's been used for many years in parts of public health. It reemerged about 2 years ago with a cascade in the United States. And it was published by CDC and the MMWR of showing the American cascade. And it was pretty striking of what the American experience was. So, do you know how many people in the U.S. are living with HIV/AIDS today? Ballpark. Who knows the figure? About 1.2 million Americans are living with HIV infection. And the goal of a prevention, care, and treatment program is to find those people, get them into care programs, manage them, effectively get them an antiretroviral therapy if they need it, and suppress their viral load, because if you have suppressed viral load, your disease doesn't progress and you don't transmit to others. So in the United States, what proportion of the 1.2 million people have suppressed viral load? 75% or more, 50 to 75, vote. How many think it's more than 75%? 75 to 50? Okay, 50 to 25, it's 28%. So in the United States, 28% of people have suppressed viral load. That means 72% of those 1.2 million are walking around viremic, meaning their disease is progressing and they're at risk of transmitting HIV infection. So in the US, we have a pretty dismal cascade, and it's much worse in many other places. So this is Vietnam, where there's about 250,000 people estimated to be living with HIV. Actually, a pretty high proportion known. In the US, it's about 80%. So in Vietnam, a high proportion known, but you get big drop-offs in people that are linked to care, retained in care, and now Vietnam's up to about 27% of the population on antiretroviral therapy, but an unknown proportion of people that are actually suppressed. But this is a very effective visual to use, and our program in Vietnam takes this down to a province level, and you're dealing with provincial health officials. It's a very effective way to talk about your goals. And clearly what you want to do is get all of these bars to grow, and it's a very effective tool for mobilizing action. It's even worse when you look at managing what's a large driver of the epidemic in Vietnam, which is injection drug use. There's a large heroin using population in Vietnam. A large proportion of HIV-infected people are drug users, and it's estimated that there are, if you recall, there are about 250,000 infected people in Vietnam. It's estimated that about 217,000 of infected people are drug users. Vietnam has been very resistant. Most of them are injection heroin users. An effective treatment for heroin use is opiate substitution, and methadone is an opiate substitution drug which people take orally, and it reduces craving, and so you don't use drugs as much. There was great resistance, and FHI, with U.S. government support, was one of the first organizations to start methadone maintenance programs in Vietnam. So we now have 60 methadone maintenance clinics in Vietnam that have got 13 people on methadone maintenance with the hope of getting them away from injecting drugs. About 22% of them are positive, and about 3,000 are antiretroviral therapy. But a tremendous room for upside in these programs to scale these up. So that's the Asian context of it. So moving on from country programs, a bit about some of our technical domains. The roots of Family Health International, FHI360, are family planning. We've been doing this for more than 40 years, and it's really a part of our DNA as an organization. What I want to talk about is one of our newest departments that we just created a few months ago. It's our Contraceptive Technology Innovation Department. And this was kicked off by an initiative from the Bill and Melinda Gates Foundation. We received a $24 million grant from the Gates Foundation to create a new initiative that would develop strategically important, long-acting contraceptives with a focus on global partnerships to ensure access to affordable and acceptable quality products for those most at need. So the idea here is that the world needs more effective long-acting methods, especially those that are affordable for women in the world. So we have, in addition to that, several other ongoing projects. I'll talk a bit about our Sino implant project, also funded by the Gates Foundation. You may know the most common contraception in Africa is an injectable contraceptive called Depo-Provera. It's every 3 months, so we're actively working on trying to come up with a new formulation that would allow the injections to be every 6 months. The challenge in all of these programs is women coming back for their follow-up visits, and if you don't get your injection 3 months later, you're at risk of getting pregnant. If you don't want to get pregnant, that's a problem. So if it's every 6 months, it just makes it much easier to administer the programs. And listed here are some of the other activities we're pursuing. But this is a summary of an exciting Gates-funded project we've been doing for the last 5 years. Sino Implant 2 is a 2-rod implantable contraceptive. It uses levonorgestrel. And so these are subdermal implants that are put under the skin and the arm, and they last for about 4 years. A very highly effective contraception because there's no adherence. Once they're in there, it's highly effective and highly safe. One of the problems in the world is that there are 2 commercially available products, one made by Bayer, one made by Merck. They're relatively expensive, and it's very hard for developing country programs to afford them. So with support of the Gates Foundation, we partnered with Dawa, the manufacturer of this product in China, to help it get registered, help with the quality assurance program, and working with the World Health Organization to get it pre-qualified for programs. So we've been working on this for the last 5 years. This is if you're interested in marketing products, this is an important chart to notice here. So in 2009, when we were getting started on this, there were 2, this is Jadel, which is made by Bayer Healthcare, and Implanon, which is made by Merck. They were marketing these in developing countries for about $20 or $25. And do you know what these cost in the US? Several $100s. So if you go to a clinic and you get an implantable contraception here, several $100s charged in the United States and Europe, but they're marketing them globally for $20 or $25. Clearly a huge profit when you sell these in the United States. But still, they're too expensive for programs, particularly in sub-Saharan Africa. So the Chinese product that we're working with, which is very similar to Jadel, and we think safe and effective, was marketed at about $8. So this, brought a new product into the marketplace. As I said, there were 25 countries we were able to get this registered to use. And we believe, because of the market pressure of a low-cost alternative to the expected branded products, just last year, both of the manufacturers brought their price down, quite surprisingly, to $9 per implant. So this has actually changed the dynamic now, and there's also been a purchase agreement from the major donor organizations to buy these products. So this has been a very interesting experience of how do you influence the global marketplace. And the Gates Foundation is quite keen on this model, and the whole idea with our Contraceptive Technology Initiative is to develop the next generation of low-cost products so women in sub-Saharan Africa and India and other parts of the world will have access to effective products. So this is the outcome of this clear public health impact. According to, we've had more than 1 million of these units distributed, so I think we've probably averted 1.4 million unintended pregnancies, more than 3,000 maternal deaths averted, and probably averted more than 175,000 abortions of women that had unintended pregnancies. We think this probably saved more than $10 million in commodity costs, and because of these savings, these companies or governments that use these could provide services to another 1 million women. So this is, I think, a good example of impact and probably a model for the next generation or so of how low-cost products coming from Southern manufacturers can change the landscape globally. Just to talk about HIV/AIDS, particularly our research activities, all of our programs embrace a combination approach, and oops, I went too fast. Sorry. I gotta go. So these are the known effective methods of combination HIV prevention. I won't go through these, but we've intended to make a contribution to the evidence base for a number of these steps in the prevention picture. Have you folks been following the HIV Research Agenda? Do you know what CAPRISA 004 is? Who knows what this is? Okay. Well, anyway, so we were investigators on this. This was published in Science in 2010, and it was really the first demonstration that an antiretroviral drug could prevent HIV transmission when used by HIV-negative people. And it was the first time that a vaginal microbicide was shown to be effective. So this was a randomized, placebo-controlled trial conducted in KwaZulu-Natal in South Africa, about 1,000 women with a very high risk of HIV infection. And the study showed that there was a 40% reduction in HIV acquisition for women using this tenofovir gel. So there's now follow-on studies trying to replicate this finding in hopes that this could become a female-controlled vaginal microbicide that can be effective for HIV prevention. So we were very proud to be part of this study. The Abdul Karims in Durham were the investigators on this study. This is another study that we did with USAID support. FemPrep was a study of oral antiretrovirals for high-risk women in Africa. We published this in the New England Journal of Medicine 2 years ago. A couple of important findings. One, that we were not able to show protection for women in South Africa and Kenya and Tanzania. But the reason wasn't that the drug didn't work, it's that the women didn't take the drug. And there was important adherence issues here. When you have to take a daily product, does it really work for you? We were also part of this groundbreaking HPTN 052 study. Mike Cohen at UNC is the PI of this study. And this showed that antiretroviral therapy for infected people reduces their transmission to other people, and it's revolutionized HIV prevention. Science magazine heralded this as the breakthrough of the year 2 years ago. So HIV treatment as prevention has really changed the landscape of HIV transmission, and we were proud to be part of that study through the HIV Prevention Trials Network. Other work we do, I'll go through these quickly. Voluntary medical male circumcision is a very effective way of preventing HIV acquisition in men. Men that have been circumcised are at 60% reduced risk. So we've been working with the Shang Ring, which is a Chinese-made product that facilitates easier than surgical circumcision. And the Prepex device is a non-surgical device that can be used for circumcision. And we've done randomized clinical trials of both of these in Africa, showing how they compare to typical circumcision practices. I think in the interest of time, I'm going to go quickly, but I wanted to cover a couple of things about nutrition. When we acquired this company, AED, 3 years ago, they have a large presence in nutrition programs now, and so it's been a real pleasure to work with this group. We hold USAID's flagship nutrition program. It's called FANTA, Food and Nutrition Technical Assistance. FANTA is currently working in 13 countries around the world listed here. A lot of it is information dissemination, providing nutrition support for country programs around the world. They also do quite a bit of dissemination of publications on complementary feeding recommendations and challenges of infant and young child feeding. A lot of it related to the HIV epidemic, and a lot of the information that they publish is available on our website here. The other exciting project we've got, the map doesn't all show up here, but the colors show up, which is important. This is a Gates-funded project called Alive and Thrive, which works on infant and young child feeding. The first phase of the study worked in Ethiopia, Bangladesh, and Vietnam, and it's a great example of a nutrition program going to scale because it's reaching 16 million children around the world, changing breastfeeding practices, young child weaning practices, with an attempt to actually decrease stunting. And the end-line assessment of this 6-year project is going on this year. And the Gates Foundation has been quite favorable about this, so Bill and Melinda Gates in particular are quite supportive. And they've given us an extension with an additional $30 million to expand the program to Nigeria and India and to do more policy work in Southeast Asia on this project. So this is a slide of an important lesson that this project teaches, that policy change can have a profound effect internationally. So in Vietnam, the Alive and Thrive project with other partners such as UNICEF lobbied the Vietnamese government to extend maternity leave. So a policy change, so a woman now who becomes pregnant gets 6 months maternity leave instead of the previous 3 months, which makes it much easier to do exclusive breastfeeding for the first 6 months of life. So this was a nice policy change, and the Alive and Thrive project is working with governments throughout Southeast Asia to try and replicate this as a fundamental way to change public health policy. Another exciting innovation in this area was bringing together different sectors that often don't interact. So we launched a project called Clean, Fed, and Nurtured, which brings together water, sanitation, hygiene, young child hygienic practices, feeding, which is infant and young child feeding programs, and nurturing, which is early child development activities, bringing those together in sort of a synergistic way. And it's kicked off and gotten a lot of steam. And we just hosted a meeting in Washington last week, bringing these sectors together. Quickly about health communication, which is sort of a cross-cutting issue. We do it in many health domains. But I wanted to talk about one of our projects that generates the best photographs of any of our work. And this is that's a bat, by the way, that's hanging upside down. So we do work on emerging pandemic threats. And so we hold a USAID award for a project called Prevent. And the EPT, Emerging Pandemic Threats, is a U.S. government-wide initiative. And you may have seen the news 2 weeks ago that the U.S. CDC launched a major health security initiative about infectious threats to the world. So the purpose is to preempt at the earliest stage possible zoonotic diseases. So it deals with the animal-human interface and posing public health threats, hopefully averting the next SARS or HIV epidemic. And USAID is guiding this. A lot of our work is in Southeast Asia. And there are USAID's funding 4 projects. One is called Predict, which is trying to identify viruses. Identify, which is a very lab-based activity. Respond, which is building capacity. And we do the part that's called Prevent, which is doing social behavior change approaches to developing interventions to both identify and decrease the animal-human interface. So just quickly, we've been doing studies in these Southeast Asian countries as well as Uganda, identifying where animals come into contact with rodents and other animals. In Bangladesh, a very innovative project, Nipah virus is a very lethal virus transmitted by bats, and trying to keep the bats from having interactions with the trees with which humans interact with, and doing a number of other issues characterizing wildlife commerce. And it's a pretty interesting world out there of the commerce in animals. This is one of the pictures from Laos showing the hygiene in markets, and it's a pretty horrendous hygienic situation here, but as this says here, this could be virtually any of these countries. And in Southeast Asia, there's a very lively rat trade. People eat rats as a common form of meat, and it's a major form of humans coming into contact with animals. And you remember the avian influenza epidemics largely were poultry related, and that's part of this whole human interface. So I think that's it for our programs, and what I wanted to talk about is for us as an organization, we've realized the importance of implementation science. You know, we generate evidence and we do programs, but there's often this huge gap, which is moving from what we know to what we do, and trying to fill that gap of how do you fill in any of these programmatic elements. We're often very poor at getting them in. I was in Geneva 2 weeks ago at a WHO meeting on antiretroviral therapy, and there are very ambitious guidelines of treating more, 10 million more people with antiretroviral therapy, but we aren't very good at doing every step of that cascade. So we appreciate a real need for being able to fill that gap of understanding what's the best way to have a program be able to implement the best science behind those. So in summary, we're engaged in a very wide range of research to both generate evidence and to have impact globally. And we're really keen to forge partnerships and collaborations, which is why I'm here at Duke today, hoping to forge some collaborations with you all, and looking for partners to help us generate evidence and to make sure that the impact of our efforts is even greater than it is. And we invite you all to come visit us at FHI360, because this is the view from our lunchroom.
Oh my God.
So thanks very much for having me over here today.